Hello. As I received here three very good investigators on COVID-19, such as Professor Rich, McCulloch, and Ioannidis, I think it was a good idea after discussing with them to make one of my conference in English to reach people who do not understand French or do not use on YouTube, where are all my presentation every week, the automatic translation. So we have an institute in Marseille, which I built, which is 17,000 square meter. We get a staff of 800 people. We get 75 bed of care, plus 20 bed for day hospitalization. All the beds are in a private room, are in depression, and one of the ward of 25 bed could be transformed to treat the worst contagious and fatal disease, because they get all the 3 level, which means that everything is secured and nothing can get out of this room and this ward if there is something very contagious. So we have been prepared for long to face potential epidemics. And in my life, since I began infectious disease in the 80s, I have been facing in France or outside number of epidemics, and I have a huge experience, probably one of the best experience in the world in facing epidemics in situations which are difficult to manage. And this is why I decided 20 years ago to do this kind of things, and partially because I've seen what China have done after the first SARS epidemic near Shanghai. This was one of the models that I used to do this building, with a huge facility for research, incredible facility for diagnostic tests and epidemiology. So as for COVID-19, this is finally the way we see the care. And I think it's not surprise, because it's looked very much like many of the infectious disease. So there is a first phase where the problem is a virus multiplication. First, during the incubation time, there is no symptoms, and then the symptoms appear that may be mostly upper respiratory with anosmia and ageusia. And in general, these people are younger and the disease is much less severe. Or directly with pneumonia, where you can see that in people who are older and in a clinical situation when they get comorbidities. At this stage, if you want really to investigate respiratory symptoms, you may use a low-dose CT scan. The usual X-ray, thoracic X-ray, is not good, and in my mind, it should be completely avoided for pneumonia in general, be replaced by a low-dose scan. Which is interesting is that people living in the eastern of the world, for us, are all equipped with CT scan, replacing traditional radiology. At this stage, of course, this is a stage where drugs with antiviral action may work. So you may use the different drugs that are available. We have not been a very big fan of remdesivir because you need a perfusion of 10 days, and many of these people are ambulatory at this stage. But if you treat them early, they will not need to be hospitalized. So, but you can use, and several propositions have been done. You know that we treat them by an association of hydroxychloroquine, 600 milligram per day for 10 days, and azithromycin, the same treatment that we use for pneumonia in general. This is the basic treatment of pneumonia. So we now add zinc. People make zinc. Some people use, when they believe that hydroxychloroquine may be a problem, ivermectin. Some people use vitamin C. Some use vitamin D. Whatever, you need to treat this patient at this stage, because it's like any infectious disease. When you get a urinary infection with Escherichia coli, or if you get an infection, cutaneous infection with Staph aureus, and you treat the patient, then you save them, that you avoid hospitalization. But if you wait too long, they go in critical care and die, despite the fact that you get very good antibiotics against Staph aureus and E. coli. They will kill people in the hospital just because it's too late. There is the whole immune reaction, and then all the tissue lesion that makes that you cannot. You will save only a part of these people, usually 20%, when they go into critical care unit. Just because you're in a lesional time. And this is what you see here. This is the first phase where you get the virus, and then it becomes a mixture of the infection and lesion caused by the virus directly, and the immune reaction, which is very strong in this disease in some patients. And at this stage, the compound which have got just an antiviral infection are not sufficient, and this is usually the time when people go to the hospital, and this is the reason why if you get a compound with just an antiviral action, it will not work. You need to get something also controlling the immune reaction, because there is plenty of antibodies, there is plenty of autoantibodies, and there is plenty of cytokines that will makes the prognosis worse. At this time also you start to see trouble with coagulation, and we give anticoagulant quite early in the disease, and we really anticoagulate the people at this stage when they get an increase of the D dimer. The other thing that we do and that we have proposed very early is as soon as a patient gets a diagnosis, you can treat him at home, but you need to tell him to check for his oxygen on the blood twice or 3 times a day to see if it's not going down. And if it's going lower than 95, they need to reach their doctor, because this may be aggravating very rapidly. In this disease, the pulmonary lesions are different. They are essentially due to the vessels. And then what we are accoutumated in this disease, which is patients who have a very severe respiratory infection, gets dyspnea, which means that they get an acceleration of the respiration. In this case, it's not the case, because there is what we call a happy hypoxia, which means they get very low oxygen, but carbon dioxide, which makes that you get a dyspnea, is not high, which is something which is a stimulus to make you perspire very rapidly. So you cannot be confident in the fact that you don't feel that you have a good respiration. You need to check it by knowing what the oxygen of your blood is, and if it's becoming low, run to the doctor or to the hospital or to the clinic, because you need oxygen at this stage, very, very, very early. So this is a critical point. So in my country, we start the equivalent of the Surgeon General start to say, stay at home, don't see any doctor, just take some Tylenol, and that's it. This was wrong. So you need to see this patient, start to treat them like you treat any infectious disease, or like any pulmonary infection, and you need to check for the oxygen, and eventually to give them some anticoagulant to avoid one of the worst complications, which is pulmonary embolism. And if they get anosmia, you need to re-educate them, their olfactive function very early. So there is on the internet, including our site, but in others, how to re-educate your smell capacity every day by smelling things. Even if you don't smell it, you need to name it, and then your brain will be re-educated to know to know the smell. So this is critical to do this very early. And now, at this stage, when you're talking about the immune response that is too strong, you need something modulating the immune reaction. And this is also why we use azithromycin and hydroxychloroquine that work on the immune reaction. You know, hydroxychloroquine have been used since 70 years, first to treat malaria, and second to treat autoimmune disease such as lupus or such as polyarthritis. So there is millions of people who have taken that without any problem. So the claiming that this is toxic is just a lie that nobody can believe, because millions of people, the year which has been the most prescribed in tropical area, 1 billion of treatment by chloroquine of hydroxychloroquine have been prescribed during a single year. So can you imagine that something like this could be toxic? It's just wrong. It's a lie. It's a big lie. It's not true. So this is the things that we've done, and I will tell you what is going on. So this is a representation of the people. You'll see how many people we've got here, but I think we have the center, a single center who make more tests than any other in the world, and who treat more people than anywhere in the world. So it's not the interpretation of the data from the other. It's not, the multicentric study where nobody know exactly who have done what. You're mixing things, and so the one writing the paper only get the data which have been transmitted. And personally, I think it's much bigger bias than having a single center with all the data that may be verifiable. So all our data, and specifically of this study, could be used by any investigators that ask for it. So what you can see here, by clustering things together, what you have in green is people who are no problem. And you can see that this is centered by hydroxychloroquine and azithromycin. If you take time to evaluate that, we know that in pneumonia, we need 3 days to evaluate a treatment. In this other end, in pink, you can see the people, what is very bad. So leading to death, leading to critical care units, and long hospitalization. So this is old age, no treatment, and very low lymphocyte and elevated D-dimer that are associated with the pulmonary embolism. And the other treatments that have been tested are just in the middle. So here you have the number of tests that we've done per day during all this crisis. And you can see that at the peak of the tests that we've done, we've tested as many as 4,000 per day. So this was huge. We need to, every day, to define a strategy to test everybody. And specifically at this time, in our country, it was not recommended to test the people that come directly. So it was suggested to test only people who were hospitalized. So this was a big difference, and we have been hugely criticized for this, but now everybody is doing this. So it's just because people didn't get the organization to do this that they don't do that. They never acknowledge that I did that 1 month before everybody, but that's what's happened. And we're still doing this, and we get a number of cases that we have tested, which is incredibly high. It's the same, this is a patient that were diagnosed positive, and the peak were as much as 400 per day that we have to manage either in daycare or either in hospital. This is the number of people that have been hospitalized, not only in my institute, but in all the university hospital. Maximum was 250 in one day. And this is the number of patients which have been in a critical care unit during all this time, and the number of deaths that have been happening in the whole hospital. So if you look at just what happened in the hospital, University Hospital of Marseille, we have tested in our institute 673,000 people by PCR. This was concerning 372,000 people, because some have been tested several times. And among these, 40,000, nearly 41,000 were positive, so 11%. And 32,000 of these people were treated by us in the institute. This is the ISU, and the other were treated in other parts of the university hospital. And you can see that we get that by daycare in 21,000 cases, hospitalization in 3,700 cases, of whom 386 go to critical care unit, and from all these people, 1.2% died. That's 381. If you compare that to the rest of the institution, 7.5% died. If you look at now at those who have been treated at least by 3 days by hydroxychloroquine plus azithromycin, we treat and we evaluate nearly 17,000 people with a death rate of 0.8%. So that means that, including those which have been hospitalized, some that have been going through critical care unit. So this is a very low death rate, which is of course, and in all the patients that we have that died, the mean age was 81 years. We never get people who are younger than 60 who died, except two that we did not understand. So the people who were younger than 65 who died got all comorbidity, very severe comorbidities, such as pathologic obesity or cancer. So this is all the data that we have, very updated on 8 June. We have tested also a lot of serology. We have inoculate, I think we get more strains of SARS-CoV-2 than anybody else. We get more than 3,500 strain. And it is interesting because based on this, we can determine what was the true positive for the PCR. For us, the true positive of the PCR is a very, very last level where you can still grow viruses, and we estimate that it was 35. So what is above this is probably a false positive or not positive. So only these cases are positive, really. So I think that our paper is a reference now to define this. So you can see that patient in daycare, there was 21, because it's emerged that maybe hydroxychloroquine was terribly toxic for the heart. So we didn't see that, and I was using the same treatment, same posology in 30 years. But just because the pressure was so high, we asked a professor of rhythmology, a cardiologist, specialist of the problem of circulation of the electricity in the earth, named Professor de Raoult, and we analyzed 26,000 electrocardiogram with him, and then he started to use watch that can make electrocardiogram and send the electrocardiogram to him to see if there is any problem with the electrocardiogram. So these have been developed as well, and I think it's maybe one of the tools that we may use for disease where we believe that you may get a problem with the earth. As I told you, we use a lot now low-dose CT scan. So specifically, at the beginning, we determine what is what people should get this CT scan based on the data that we have. Now we do that mainly when we see that there is a oxygen level in the blood which is low. We ask for a CT scan and see image that we have never seen before. And now, because it's a CT scan, there is a artificial intelligence that analyze the CT scan itself and makes that very, very interesting. One thing that we're doing now is a PET scanner to analyze the long COVID or post-COVID, specifically the brain and the thoracic problems that we can see in this patient. Some patients get pain, thoracic pain, and we can see that they got inflammation of the aorta, big vessels that you get in the thorax, and we don't know exactly why. And then we have now a little bit more than 20,000 people where we analyze the virus to define which variant is involved. And I will discuss a little bit more than this. And we have sequenced 10,000 genome of this virus. This is 18% of what have been done in France, which was a little late compared to the other. But we are vaccinating people as well. So we are vaccinating here. We have vaccinated 10,000 people. We're the first in Marseille center to vaccinate people. This is, I'm going to tell you about the different virus. What happens is that if we go back to this very first slide, you can see that we get the first outbreak, and then the epidemic vanished and come back in July. Then I was seeing that I was in holiday, but looking every day what's happening in the institute. And when I see that it was going on, I never believed that it was what people call a second wave or rebound of the disease. I think it was a new virus that did that we call variant. And we identify this variant to be realistic in August. I start to speak about this, try to publish that for 3 months, and was rejected everywhere. In fact, the name variant was not accepted until the English published the UK variant. But the variant that we have, I will talk about a little bit, was much more severe and long. We call it in Marseille 4. And you can see here, this is the different months that you have up. And down in color, you get the different variants. So we start by having the Chinese variant to begin. And then we start, which is in white. And then we get nearly nothing, in May. And June, we get only 2 cases. And then it starts to burn in July. And then you can see that in July, we get these new pink one, which is what we call Marseille 1, and it comes directly from North Africa by boat. So we identify the source, and then it was replaced by the violet one, the pink one. That becomes the more important here and the more common. And why did we define a variant? This is the virus that we have sequenced in my lab. Is that you can see that some of these viruses are in a different branch, very long branch. So this is the UK variant, and in yellow it's a Marseille 4 variant, and in blue clear it's a Marseille 5 variant. So the Marseille 4 variant is also very far from the other, and the different points that you can see here, represent the number of mutations that appear as a wall, like that. They were not like at the beginning of the outbreak, where you can see one with one mutation and one with two mutation and one with three mutation. In this case, many mutations appear in a single time, which means that something happens that is very different than just the evolution of the virus by itself. In the meantime, it doesn't make sense that you have a virus with plenty of mutation after a moment where there is no case at all. So we get no epidemics, and when the epidemics come back, it come back with a virus with plenty of mutation. So one was coming from North Africa. By sequencing the sample from people that we know in Africa, we know now that it come by in West Africa, Sub-Saharan Africa, then go to Maghreb, then come in France. So this was the source. As for the next one, the big Marseille 4, we suspect quite early that it come its source in mink farms. In fact, in May 2020 was observed an outbreak in Netherlands of SARS-2 in mink. So I need news that there is so big mink farms in Netherlands. Now, after this, it go in Denmark. In Denmark, they have killed these 17 million of minks that come from mink farms because they were infected. And as early as May 2020, so we knew that this virus in minks were susceptible to infect human, as much as 2/3 of the people caring of the mink farm have been infected, and some have transmitted that to their family. So we knew that these mutants that multiply like mad in the mink farm are infectious in human. And then I suspect for a long time that these variants that begin in France, the number 4, that begin in France, have its source in minks. We have 4 big mink farms in France, not so big as Netherlands and Denmark, but they were not surveyed until November. In November, one of these farms, the minks were killed, and I tried to get samples or got the sequence because I suspect that it was the source of this big variant that invade all Europe and part of the world, and it take 3 months and a half before they release the sequence, and the sequence on GSED, the bank where we put all the sequence, is just in the middle of this virus. So this virus is from human and mink, but because its source is in France, and because there was no case before this, I believe that the source are the minks. This is a reservoir that was ignored for a long time, and probably there is other reservoir in other animals close to the minks that are carnivore rodents. So this is an illustration of this different wave outbreak by the time. So you can see here there is the first one that come from Wuhan, and we get immediately a new variant in Europe that go everywhere. This was June, and then in July there is another one that you can see here. That's Marseille one that come from North Africa, and then there is another one. This is Marseille 4, and this one is spreading everywhere, and then the UK variants start to appear. Now you can see that behind, and replace the Marseille 4 for a reason that I don't know how a variant takes the place of another one. And now it is vanishing a little bit everywhere, but now it tends to be replaced by the Indian one that is coming and spreading currently. So this is what happens. So if you look at the patient now who are infected in our place, you can see that now the proportion of people vaccinated is growing as much as the vaccination increase. So we get nearly 600 people vaccinated with one dose or two doses with one vaccine or another one, and the fatality rate is the same, the hospitalization rate is the same. That's what we've done. It seems that the Indian is specifically resistant to the different vaccine, because half of the case of Indians that we have been observed in people with vaccination. In contrast, the number of people who have been reinfected is very low, is 10 times lower than that of people with vaccination. So the natural immunity, like in any other disease, is much better than the immunity conferred by vaccine, whatever the vaccine is. And this is a percentage of vaccinated versus non-vaccinated that we have now. And as you have seen, so this is UK, but it is going as well in Israel. The country which have been more vaccinated, such as UK with AstraZeneca, see now a rebound of infection, mainly due to the Indian variant. And in Israel, I don't know which variant is coming on, but they have been vaccinated by Pfizer, not by AstraZeneca. So that means it's not magic, the vaccination. It may help specifically, like for flu, the patient at risk, which means the people older than 65 years. In contrast, AstraZeneca is probably not cost effective for women younger than 50 years, because it has been described that specifically in this population there is thrombosis, which means blood clots, and a death rate which is superior to that of the disease itself. So not only you're not sure to get the disease, but the disease itself will not kill the woman younger than 50 years if they don't get another comorbidity. So for AstraZeneca, for me at the minimum, it's clear, and now in many countries it's not allowed anymore, just because it is worse than the disease in women younger than 50. So it's been it's been quite impossible to treat this disease normally, because there is too much emotion, too much money, and it's become the worst scenarios that I've ever seen. I've seen published in the New England Journal of Medicine and the Lancet, which were our reference journal, in which I published a lot papers that no student in my place would have accepted, because it's just unbelievable when you tell that 10% of people with hydroxychloroquine will die or cardiac arrhythmia. Just ridiculous. Nobody can believe that. The same, the people who publish that publish also another paper on cardiac troubles with COVID-19, and these people, nobody know where they get the data. They probably never get data. Nobody sues them. I don't know why. It's false data. It's not true. It's not possible. When you read that the papers, they pretend that they have data on more people in Australia that there is case in Australia. So nobody can believe something like this. How can this has been reviewed and published. It's just unbelievable. That means that everybody get mad with this story. So it's hard to know what is a part of the madness, what is the part of the corruption by, the incredible money that people have made out of it. Gilead have made $1 billion of benefit with a product that people who have tried that say it doesn't work. How is it possible? And the profit that Pfizer expect to get this year is $21 billion. So of course the money is so huge, the fear is so huge. The reference people are not very, very, very calm, and it's paradoxical that the rich country suffers very much more than the poor country. So it's mostly Western Europe and USA gets the highest level of death with this disease. And if you compare that to Africa, we're ridiculous. So this is really interesting to see what happens. So in the meantime, because of this, we decide that we need to explain what we do and publish what we do. So there is some journal accepting our papers, but the reference journal don't even review our papers. They put that directly in the trash. So we decide to get our own preprint site, which is here. You can send it here, and we control the quality and put that online. And interestingly, these papers have been incredibly seen and download. So there is probably a new model of publications that will appear that will be independent of the big journal who are not belonging to a big cash machine and do not reflect just science, but what people believe that it should be. It's the same for communication. Now we get our own TV. This is what you see, which is on YouTube. And now we get something like 70 million view on this. And this is to compare to other institutes in France. And you can see that, and it's growing, of course, and you can access that. Many, probably near 20 of these communications that I did in general on Tuesday have been seen by more than 1 million persons. So we can resist to the pressure of the media, which are very, very, very direct in one direction and do not make enough room for thinking or giving data. In here, we just give data. And after the time, all the data that we had were confined, of course, because they are data, they are not opinions, but data. People never recognize that the data that we gave were saying what's happened. And we see that earlier because we get the biggest place to see and observe what was happening. So this is the number of followers of our TV, and that's it. So finally, I'm sure that we need to get this kind of institute with everything, the research, the huge diagnostic capacity, the capacity to see the patient, make daycare, to observe things and not become enter in the digital medicine that make people who have never seen one of these patients tell you what you should do and what's happened and how do you do things. Medicine still need doctors to see the patient, care of the patient, because if you don't do this, it's worse. And then we need to come back to a little bit of confidence in the doctors, and the doctors should have confidence in themselves, treat their patient as they treat themselves or as they treat their own parents. Go back to what medicine is. Medicine existed before evidence-based, and people were treated. People with plague in 1720 in Marseille where there was a huge outbreak, were treated. We get the books, the ways they were treated, and when they were treated, the death rate was lower than when they were not treated. This is medicine. Okay.